factors that I consider before initiation of treatment and what type of treatment I'm going to use are basically the patient performance status and how aggressive the disease is or not. So this is a disease, let me start by saying this is a disease that affects patients, elderly population. It's more common in male than in female. And that's another difference between mantle cell lymphoma and other type of lymphomas. 3 to 4 higher risk in males compared with females. So number one, so this elderly population. And then if the disease is aggressive, so then I will try to see how fit is the patient to receive my therapy. So if the patient is fit, I will consider patient with aggressive disease, I will pursue chemoimmunotherapy induction treatment, consider the patient for autologous transplants as consolidation, and then follow with maintenance rituximab. Because that sequence has shown to improve overall survival as a frontline therapy for patients with mantle cell lymphoma. So unfortunately, this is not for everybody. The large majority of patients are not going to be eligible for autologous transplants. So therefore, so we are looking for treatments that the patient is going to be able to tolerate, treatment that is going to be able to induce a response, and then particularly I use maintenance rituximab in those patients that are not candidate for transplant. There is a long-term follow-up from the German group that probably we are going to discuss later, in which they shows that patients that receive R-CHOP induction followed by maintenance rituximab, you improve progression-free survival and overall survival. So I think it's important to keep that in mind.
The first thing I need to make sure I clarify is that maintenance approaches are applicable for both elderly and younger patients. And we have 2 large trials to inform those decisions. The first is by Kluneman. This is the New England Journal paper where R-CHOP followed by R-maintenance seem to come with the benefit in progression-free survival and overall survival. This absolutely informs my therapy. And if you look at those survival plots, they're almost what we were seeing with autologous transplant, followed by the Nordic regimen in younger patients, in those under 65. That's a big deal. And I think that really tells us something. The next, I think, most important randomized data come from the French, and this is the CHOP DHAP trial followed by autologous transplant, in turn followed by 3 years of maintenance rituximab, where again we're seeing a very clear improvement in progression-free survival. And so now the real question is, who don't we give maintenance to? And based on these results, is there still a benefit for transplant? I think the next piece of data to inform this decision-making is the data from Brad Call and the ECOG/Alliance group looking at BCR-CVAD. In their study, patients, it just so worked out that patients came off the protocol, and about half ended up going to transplant and half ended up going to maintenance rituximab. Again, this was not a randomized trial. This was not a planned randomization. But it's the way that it panned out. Interestingly, the older patients tended to go to rituximab. So if anything, they were a higher risk population. But otherwise, the groups just, again, by virtue of their inclusion and exclusion criteria, seemed to be pretty well balanced. And there was no clear benefit for the autologous transplant. There is an ongoing Alliance trial. Tim Finsky is going to be running this. And this is going to hopefully answer the question. And it's basically saying, hey, independent of your induction, you want to give R-CHOP, give R-CHOP, BR, give BR, Revlimid, Rituxan, again, independent of your induction. We're going to assess MRD. And if you're MRD negative, we're going to randomize you. Rituximab maintenance versus auto transplant and rituximab maintenance. If you're MRD positive, we're going to do autologous transplant and rituximab maintenance. We feel that, okay, there's still enough disease left behind after your induction that we want to try to deepen that if we can. So there won't be a randomization there. But I think we will learn from the randomized approach, is there a benefit for further intensification in these patients, and what is the magnitude of that benefit? So a very cool trial, one I'm looking forward to seeing the results of.